Hi there, my name is Davis Lakeman. The date is September 13th, 2019, and I have chosen to start my Unit 2 case connection with Case 3. In this case, a 5-year-old child is brought into a pediatrician's office with some concerning symptoms. Let's just call the child Billy, so it's easier to talk about him. Billy's mother is concerned because Billy seems sickly and tired. She says that Billy has also been displaying excessive thirst and he has been urinating at an alarming rate. Initial assessment of these symptoms suggests that Billy may be diabetic. If Billy is diabetic, then his skeletal muscles are unable to take in sufficient amounts of glucose from his blood. A deficiency in the uptake of this optimal energy source could account for Billy's drowsiness. Additionally, high levels of glucose in Billy's blood would cause his renal filtrate to become hypertonic, thus drawing excess fluid out of his system. This would account for Billy's excessive thirst and frequent urination. A glucose loading test is conducted to determine whether or not Billy has diabetes. The results of Billy's blood work show that he has deficient levels of insulin both before and after the glucose load. This confirms that Billy has diabetes, and this also demonstrates that Billy has diabetes type 1, meaning that his body produces insufficient amounts of insulin. Given his condition, it is likely that Billy's fasting blood glucose levels will remain elevated if untreated. This is because Billy's skeletal muscle cells and adipose cells are dependent on insulin for glucose uptake. Without sufficient insulin, these cells cannot take up glucose, thus it will remain in the blood. When it comes to skeletal muscle, untreated diabetic metabolism is much like fasting metabolism, because glucose is not available as the main energy source in either situation. For this reason, glycogenolysis and gluconeogenesis pathways are likely active in Billy's current state. Glycogen phosphorylase is an active regulatory enzyme in glycogenolysis, and pyruvate carboxylase is an active regulatory enzyme in gluconeogenesis. For my second case, I chose case 4. In this scenario, a 2-month-old baby, let's call her Annie, is suffering from jittery spells, which have been occurring several hours after breastfeeding. Initial blood work reveals that Annie is hypoglycemic. Administration of epinephrine causes an increase in Annie's blood lactate levels, but her blood glucose levels remain low. Further examination reveals that Annie has an enlarged liver. Additionally, it is found that breastfeeding temporarily increases Annie's blood glucose levels, but they drop back below the normal range within a few hours. Given Annie's symptoms, the most feasible diagnosis is hereditary fructose intolerance. This condition is characterized by a deficiency in or the absence of the enzyme ATAlase B in the liver. This enzyme is responsible for one of the rate-limiting steps in fructose metabolism. Dysfunction of aldolase B leads to an accumulation of fructose 1-phosphate in the liver and a subsequent lack of free phosphates in liver cells. One way this condition presents itself is with hepatomegaly, which is consistent with Annie's condition. Additionally, the removal of free phosphates from liver cells inhibits hepatic glycogenolysis and gluconeogenesis, which would normally be used to maintain fasting blood glucose levels. This explains Annie's fasting hypoglycemia. Under normal conditions, the addition of epinephrine would enhance hepatic glycogenolysis, but in this case, the activity has been inhibited by the lack of free phosphates in Annie's liver. The epinephrine does, however, still have an effect on Annie's skeletal muscle cells. In these cells, the addition of epinephrine enhances glycogenolysis, causing an influx in glucose 6-phosphate. Being that skeletal muscle cells lack glucose 6-phosphatase, glucose 6-phosphate cannot be converted to glucose and expelled from the cell. Increased pyruvate production cannot be expelled from the cell. Instead, the excess glucose 6-phosphate is fed through the glycolytic pathway, leading to increased pyruvate production. Some pyruvate is then reduced to lactate in the regeneration of NAD+. This lactate then enters the bloodstream. In short, epinephrine enhanced glycogenolysis. Epinephrine enhances glycogenolysis in Annie, epinephrine enhanced glycogenolysis in skeletal muscle and had no effect on glycogenolysis in the liver. This explains why Annie's blood lactate increased. This explains why Annie's blood lactate levels increased in response to epinephrine, while her blood glucose levels remained unchanged. Finally, let's rule out some of the other possible diagnoses. Like hereditary fructose intolerance, galactosemia is also characterized by hepatomegaly, but this is also accompanied by a loss of appetite, vomiting, and an elevated erythrocyte galactose 1-phosphate concentration in galactosemia. Since Annie is not displaying these symptoms, it is unlikely that she is suffering from this condition. Glycogen storage disease also presents much like hereditary fructose intolerance, but symptoms also often include hyperuricemia and hyperlipidemia, which were not mentioned in Annie's case. Lastly, glucose 6-phosphate dehydrogenase deficiency occurs almost exclusively in males and typically presents as jaundice. Neither of these characteristics are consistent with Annie's case, so it is also highly unlikely that this is the diagnosis for her condition. That's my whole presentation. Thank you, and bye.